Challenges such as social isolation, loneliness, anxiety, difficult handling emotions, depression, and suicidal thoughts. These emotional health challenges are predominantly reported by parents of children who were between the ages of 9 and 12 years old. Even prior to the pandemic, Ohio data painted a worrisome picture. 1 in 7 children had 3 or more adverse childhood experiences, ranking us 46th worst out of all 50 states. More than 500,000 Ohio children aged 17 and under and young adults aged 18 to 24 had a mental illness or substance use disorder. And our state's rates for teen suicide has increased 46% over the last 4 years. These are some of the reasons.
Oh, really? Okay. Here, I was just about to email you.
These are some of the reasons why this month our Ohio Legislative Children's Caucus will be discussing legislative strategies for Ohio lawmakers to support statewide and local efforts to address critical barriers to child behavior health care and prevention, including stigma surrounding mental health care, workforce shortages among behavioral health professionals, gaps in accessible care, and long wait times for care for young children who seek help. We are also focusing on stark racial disparities in health challenges and deaths by suicide among children in Ohio and across the nation. We have a distinguished super panel here today to help us explore this topic. I'd like to start with Mr. Orman Hall, the executive in residence at the Ohio University College of Health Services and Professions and the senior program analyst for the National Emerging Threats Initiative. We'd like to hear about what does the data tell us about trends in child mental and behavioral health over the last decade, and how did we get where we are today with the increasing incidence of youth suicide and rising behavioral health challenges among children. And if you could also share findings about your report from the Ohio Alliance of Population Health, and please provide data disaggregated by race so that we get the full view of this equity issue.
Senator, thank you so much for the very kind introduction. Allison, yes, and if you could leave this slide up just for a second while I make my preface comments. My comments are going to focus mostly on Ohio mortality data, those people more specifically adolescents and young adults that have passed away from behavioral health disorders over the span of the last decade. What I would like to do first, however, is to give you a broader frame in terms of how behavioral health disorders have affected our slides overall.
I can't increase the volume here.
So I think we have some, Allison, I think we may.
How do I increase the?
We may want to mute some people on the line. Is anybody else hearing voices?
I am.
I think I took care of it, Orman. I think you can go ahead. Sorry about that.
No, that's okay. Again, what I want to do is start with a broader frame in terms of how behavioral health disorders, more specifically diseases of despair, have affected our state overall. And then we'll drill down into data that is specific to adolescents and young adults. So just from the standpoint of the overall picture, from 2010 through 2019, Ohio experienced 53,632 deaths associated with diseases of despair. Diseases of despair encompass overdose deaths, suicide fatalities, and alcohol-related suicide. So 53,632 deaths. Those almost 54,000 deaths also accounted for 1.9 million years of unnecessary life lost, and And Ohioans in aggregate, Ohioans overall, lived less than a year longer than they would have if nobody had died from diseases of despair. So mental health disorders and substance use disorders have had dramatic and very serious effects on Ohio in general over the standpoint of the last decade. Now let's look for a few minutes at how these diseases have affected adolescents and young adults. Allison, if you could move to the next slide, please. So what this slide does is it looks at the total number of deaths associated with major causes of death in the state of Ohio for persons between the ages of 12 and 24. These deaths are by year from 2010 through 2019. So what I would point you to are the last two columns, the change and percent change. And what we see here is that accidents were the number one cause of mortality in the state of Ohio for this age group. There were 3,146 deaths in that category, but there were 50 fewer deaths in 2019 than there were in 2010, for a 15% decline in this category between the 2 years, the beginning and the end year of the period. Now, if you move down to unintentional overdoses, the second cause of mortality for this age group, what we see here is that there were 113 more deaths in 2019 than there were in 2010, and it was a 78% increase. So this particular cause of death accounted for the greatest increase of any cause of death in the state of Ohio for persons between the ages of 12 and 24. Unintentional suicides, intentional self-harm, which are suicides, was the third leading cause of death. And this particular disease state saw a 36% increase. The other thing that I would mention on this particular slide is that if we excluded unintentional overdose and suicide, there would have actually been fewer deaths among this age group than there would have been with these categories. So unintentional overdoses and suicides saw the greatest increase among all disease states in the state of Ohio for persons 12 to 24. Allison, next slide, please. This slide looks at deaths by race, and we're just comparing African American and white deaths in this particular slide because the deaths for persons other than these two categories were subject to pretty significant suppression rates. But what we see here is that whites were more likely to experience deaths by accident. They were also more likely to experience unintentional overdose and suicides. African Americans were more likely to experience deaths by homicide. All of these categories should be a significant concern, and it does paint a somewhat different picture in terms of the types of diseases and problems that that persons of different racial characteristics are experiencing in our state. And then, Allison, the last slide, please. This looks at the same data for persons of Hispanic and non-Hispanic origin. So what we see here is that the persons of Hispanic origin were somewhat more likely to die from accidents, but somewhat less likely to die from overdose and suicides. Overall, when you reflect on the major changes in terms of this age cohort, again, persons between the ages of 12 and 24, we have seen significant increases in deaths associated with diseases of despair for persons in this age cohort. It definitely requires policy attention and additional work on our part. And with that, Allison, that concludes my comments.
Thank you so much. Certainly appreciate it. And we're going to ask questions at the end of this series. Next panelist is Dr. Whitney Ragland Bignall. pediatric psychologist at Nationwide Children's Hospital and Linden Primary Care Center, and clinical assistant professor at the Ohio State University. We'd like to hear about what is the on-the-ground reality that pediatric behavioral health professionals are seeing today amid the stressors of COVID-19.
Well, the reality is it's really challenging right now. It's challenging for a multitude of reasons. I think the one thing that we need to think about is many of these things were already happening and we were already struggling as a system, and the pandemic has come and kind of put a catalyst of making things a lot worse. And we have seen, as talked about before, an increase in suicidal ideation and behaviors. I unfortunately do so much safety planning, more than in my whole career in the last maybe year and a half, because so many of my patients are wishing that they were dead or thinking life would be better for them if they were not here, and trying to keep them safe. We've also seen significant increases in disordered eating, and anxiety, specifically around social anxiety. You know, when the pandemic first started, social anxiety first got better for those who had anxiety because they were not around people who made them anxious. But actually, the more that, you know, you're away from people, you are not practicing the skill. We know with facing anxiety, you have to practice. You have to face your fears. And so many of our kids now are having to go back to school, and they have lost all this amount of time to practice. And so their anxiety is a lot higher. And then overall, people are stressed. And when I think about stress, I'm talking about stress in layers. I think of it more like an onion. You know, you have this inner stress within their personal little selves and their families at home. You know, sometimes, you know, families already had some dysfunction, but when you don't get space from one another and you're there talking and living that stress with one another all the time, that can be very challenging. And then there's the stress, you know, when you have to go to school or you're at home trying to do school virtually and you have an IEP and learning challenges and you can't get that extra help, and your parent doesn't maybe have the skills to give you the understanding, or you have 5, 6, 7 brothers or sisters and you're all trying to use 1 or 2 computers, and it's just really, really taxing. So you have all this like interpersonal school stress. And then especially where I work, there's community stress. So there's a lot more people are stressed. And so we see a lot more violence. And so our kiddos are being exposed to all these different layers of stress, which are causing them to have all of these behavioral health challenges that we knew were already there, but have definitely worsened them. And now their parents are stressed too. So the people who are there to usually shield our kids in a special way are trying to deal with economic stress and trying to balance having a job and teaching your kids, and it can be a lot. And so sometimes their ability to be patient or use different parenting strategies can be harder. And so we're seeing all of these different things. And so it does make a system that was already stretched a lot more stretched. And I'll be honest, you know, our workforce is tired, and we're trying to open more slots and help these wait lists, but it can be really difficult because the lists are getting longer and longer because more and more of our kids are being affected. And so I think on multiple layers, you see this burden and stress that's happening on the ground. And I just wanted to kind of just share just some personal like experiences. You know, I work inside of a primary care office, and I chose to work inside of a primary care office because I'm very passionate about increasing access. We know that there's lots of health disparities out there. It's hard to get certain populations in those outpatient buildings seeing people. And so it's why I wanted to work in a primary care office. But one of the things that I will tell you, even being here where my focus is to get people quick access and then to some of the specialty care they might need, those wait lists are really long. And so you have families who come and they're saying, this is a problem, and they cannot get that child who we see clearly has autism being seen for a long time to be evaluated. Or you see that they're getting more and more depressed, but they're just on this wait list. And like, as much as we try to bridge here in primary care, you know, not every primary care office has a psychologist. And so kids are going without those needed services. And so parents become more and more stressed. I've had so many parents already, the school year just started and their kids haven't been in the school building very long and they're already getting suspended. They have anger, they had all this stress on them. And one of the side effects of stress is anger, and they don't know how to cope with it. So they're getting kicked out or they're overwhelmed by the amount of work they now have, and they don't know how to cope with it. And so they're acting out in many different ways. And now a parent who was excited to have their kid back in school is getting called by the school over and over again to come pick their kid up. And so there's more challenges with that. And so there are issues in regards to our workforce. We are always trying to hire more and more people, but even before the pandemic, we never had a system, I think, equipped to handle all the people that needed these services. And now we have even more people being referred. So that's kind of overwhelming our system. With the pandemic, it brought telehealth, which I think is exciting to have telehealth. But I will tell you that with that comes some challenges. It disproportionately helps some more than others. It's hard to have consistent internet access and the devices that allow you to do telehealth consistently. And I think that we have seen, some disparities in regards to uptake in telehealth as well. And some families really want to see people in person, and not all of our agencies are allowing that kind of service right now. So on the ground, I think we see this increase of patients with many different concerns. We're doing our best to try to be adaptive and find ways to help them, but it's still very much challenging and we're still working.
Great. Thank you for sharing those experiences. Next on the panel, we have Jennifer Vargo, Director of the Office of Whole Child Supports, Ohio Department of Education. Director, we know that schools can positively impact academic success and educational attainment through student wellness and health improvement efforts. And we know that schools are entry points for behavioral health services for many children who may otherwise go untreated. Can you help us, though, understand the critical role schools are taking to meet the challenges we're seeing in child behavioral health at this time and in the long term? And then if you could please highlight some examples of what Ohio Department of Education is doing to support the whole child and increase behavioral health services and providers in schools.
Absolutely. Thank you, Representative Sykes. So glad to be here today on this important conversation. I'm going to start by saying, so the agenda that I have for today is to talk about the school's role in supporting students' mental health. Also talk about what are some of the mental health supports that are being provided by the school. And then I will talk about the cross-agency partnerships are being formed with our state agency and other state agencies to help support mental health. Next slide. So it starts with the Ohio Department of Education has adopted Ohio's Whole Child Framework. That's what you see in front of you. And Ohio's Whole Child Framework is focused on making sure that when we are supporting students in our education system, that we are looking at them from a whole child perspective. Next slide. And this came from our Each Child, Our Future. This is Ohio's strategic plan for education. And what we heard time and time again from educators and parents and others was that if we did not focus on the whole child at the center of our work, we would not be able to have the academic achievement that we are hoping for. And so in regards to the whole child, we believe that in order for students to be successful in school, they must be healthy, they must feel safe, they must have supportive and caring relationships, they must be given challenging and engaging schoolwork and activities. And if they have those things, they will be better able to engage in school and will come to school ready to learn. Next slide. So the schools have adopted, so in the strategic plan, so now educators see that their role is not just supporting the academic and the intellectual education of students, it's really to support whole child needs. And the schools are doing that through a tiered support system. This is our positive behavior intervention supports framework. But in that framework, we have mental health supports that are tiered to support every child as well as each child. And what you see in front of you is the universal strategies that schools are using. So in order to help prevent at-risk behaviors, such as drug use, suicidal attempts, other violent behaviors, we are providing our students with certain strategies to help them cope. Some of those strategies are specifically teaching social emotional learning. We have social emotional learning standards, and teachers integrate social emotional learning throughout their instruction. And in that learning, students are learning to focus on, have some awareness about what they're feeling. Also, they learn problem-solving skills. They learn empathy and how to relate to other peers in a positive way. So we're trying to build this foundation of support within each child so that they can have strong peer-to-peer relationships. We also have a lot of prevention education programs. And prevention education programs are typically evidence-based programs that either focus on positive youth development, they could focus on specific at-risk behaviors that we're trying to accomplish, or trying to address. And in the last legislative budget, House Bill 166, $18 million was actually given to our alcohol, drug, and addiction and mental health boards to partner with school districts to provide prevention education programs. And so that was a wonderful push to help schools partner with someone who has expertise in mental health and prevention, and to get prevention supports. We are also seeing a lot of peer-to-peer groups happening in schools. I was talking to some students just the other day, and they were talking about how there's a greater deal of awareness around mental health. Students are talking about it, teachers are talking about it, but there's still quite a bit of stigma that's related to it. So I think schools are really working on creating these peer-to-peer groups, so students can feel comfortable reaching out to another peer, and then peers would have what they need in order to link that child to a caring adult that would help give them the support that they need. Another prevention program that's happening on the universal level, and again, this is for all students, is teachers are using trauma-informed practices. And we hear about trauma coming as a result of the pandemic, but there's been trauma for a very long time, and it's intergenerational. And so schools are really starting to understand what ACEs are and how trauma impacts the brain, how trauma impacts learning. So there's a lot of schools right now that are getting professional development on trauma-informed practices and incorporating trauma strategies in their classrooms. And then finally, as a universal strategy, some schools are implementing universal screeners. And these screeners are mainly to find students whose behaviors are underlying and may not be, and are internalizing as opposed to externalizing. These are students who may not cause attention to themselves, and then we don't find out that they've been hurting, emotionally until something has happened. Next slide, please. Another thing that schools are doing is they're providing targeted mental health supports through small group interventions. So if a student has a higher level of discipline, or is having more absences, they're showing signs and symptoms that something else is going on, there will be small group interventions based upon the need. There may be groups that are focused on grief, on divorce, on drug and alcohol abuse, on bullying, and so these skills are to help address a particular issue, and then to also teach students certain social skills around those issues. Again, there are more trauma-informed practices that are happening at the second level. Check and Connect is one of those tier 2 services in which a student is identified needing extra supports. A caring adult will check in with them the first thing in the morning. They'll set some goals. They'll talk about, what the child needs to do in order to achieve those goals. And then they'll check them at midday and then at the end of the day. And that's very much a trauma-informed practice. It helps to build relationships, and it helps to that child has a caring adult who they can process with as they're, working through their day. Next slide, please. And then lastly, that we have tier 3 intensive supports, and most schools are connected to some mental health provider. And this is growing more and more. With the student wellness and success funds that were given in the last budget, many districts have used some of those funds to partner with local mental health providers, and they're finding different ways to provide prevention, intervention, and treatment services, either in the school or linking families to them in the community. Also, schools are partnering with community organizations to provide caregiver training as well. Sometimes parents need a little bit of support with how to help their child if they're suffering from trauma, or if they have other, other conditions, mental health conditions. And so some schools are linking with community organizations to provide that support. And then, as I said, we're seeing many more mental health personnel in the buildings through a variety of ways that schools are working with community providers. The one thing that I will point to is Dr. Ragland-Bernal had said something around telehealth services, and that there's some inequities that are involved with telehealth services. And on the next slide, the Department of Education is partnering with the governor's, a governor's group that has the Ohio Department of Mental Health and Addiction Services, the Ohio Department of Health, and also Broadband Ohio. And we're delivering telehealth services to students in Appalachia. We also have a grant that we received from the federal government. The department received the grant from the federal department to increase to increase mental health personnel in Appalachia, Ohio, because we know that that's an area of need. We are also working very closely with the Ohio Department of Mental Health and Addiction Services. We meet with them. We have a standing meeting every other week, but we usually talk once a week. We're either talking about how to help strengthen the implementation of that K-12 prevention education, which was the $18 million that I talked about. Last year, there was lots of conversation around suicide prevention. It was all in the papers of, students attempting or there's being more hospital visits. And so mental health obviously gets the information, as does the Department of Ed, and we come together to think about what can we do collectively to help address the issue. We actually launched a suicide prevention campaign last year, where we put together a variety of resources and targeted specifically our educators so that they knew what resources were out there, helplines for both students as well as for educators and adults and for families. And we're also working on a student assistance program. That program is to help implement, strengthen the implementation of a comprehensive system of support for students specifically focused on their mental health, whether it's providing prevention programs, making sure that there is a really good intervention and referral system, a connection to community partners, and case management around those students. So we want to make sure that students are being identified and that their needs are being appropriately addressed. We're working with the Ohio Department of Health, as well as the Ohio Department of Mental Health and Addiction Services, on addressing ACEs, the adverse childhood experiences. We're looking right now at what are Ohio's most prominent risk factors. And then finally, the department is also working with the Ohio Department of Mental Health and Addiction Services and the Ohio Department of Public Safety. And we're developing a school safety framework along with strategies, because there's physical safety and there's emotional safety. And oftentimes in schools, they are approached in two different ways when they are, they're incredibly linked. And so House Bill 123 provided us with some requirements that schools must have, such as grades 6 through 12, they have to have suicide prevention and violence prevention curricula in their health education programming. So we are working with DPS and Ohio Department of Mental Health and Addiction Services to make sure that from a emotional safety and a physical safety standpoint, schools are providing comprehensive services. And that is all that I have to offer for today.
Great. Well, thank you so much to all three of our panelists. I know that was extremely informative, and this has already sparked a lot of discussion. So I'm going to get to the questions that were posed in the chat and in the Q&A function. I would encourage anyone that has a question to please put it in the chat, or if you are a legislator, I believe you can unmute yourself and ask a question. So I'm going to start right now with the questions that have been posed already. And the first couple were for Mr. Hall. So one person asked they'd be interested in hearing why a lot of teen suicides happen within 24 hours of a fight or a relationship issue, and wanting to talk about if there's anything that you have that points to the effects of social media and also in-person relational difficulties contributing to this. So Mr. Hall, if you want to go ahead with that one.
You know, that's a really good question. And I'm really sort of the data person. We might want to, I might want to punt that to one of our clinical experts that could potentially have more insight into that particular issue. So maybe Dr. Raglan Bignall or our previous or our immediate past panelists may have more insight.
I mean, I don't know, like, if there's, I don't have the data totally on my front of my mind, but I will say that, you know, our kids' social interactions are so important. You know, having friends, what they say to you is really important, and being liked. And so these things happen in emotionally charged ways, and a lot of those reactions are impulsive, you know, where you feel like this one interaction is going to be something that is going to ruin your life or make sweeping judgments of those kinds of interactions. And so I find that after something has emotionally charged has happened, we might not have the coping strategies to handle it or take a step back. And so oftentimes the responses are just in that moment because it's so distressing to them to either be in that argument or that fight or to be bullied at the time. And so sometimes it's just that we don't have the coping strategies at the moment to handle such a negative interaction with someone else.
Thank you very much for that response. And keeping maybe focus on Dr. Raglan Bignall, there were some questions posed about how to improve and increase in the workforce shortage that we have in behavioral health, and perhaps even improve our availability of services. And another question along those same lines, do we have a strong enough behavioral health workforce to support this type of work? So if you could answer that, that'd be great.
I definitely think that it's an area that still needs growth. And so I'm hoping that programs are recruiting people even in high school to join us because it's an ever-growing field and we need to grow it exponentially to meet the need. I think partnership is really important. Sometimes organizations work in silos, and I think the best thing that we could do is communicate with one another about who's offering what services and how we can link our patients or students to the right service at the right time. So we're not duplicating, but also that they're getting just what they need. And I think sometimes patients, from my experience, are on wait lists for a really long time. And so by the time their number gets called, it's so far from where they are now that they miss those appointments. And so we have a lot of no-shows. And so thinking about how we can get patients in sooner to reduce those no-shows when it's an immediate concern can be really helpful too. So I don't know if I have all the answers to those things, but I do think if we work together in building a system that communicates more, we'll probably do a lot better of a job than we are currently. And just getting our kids to come into this field because it's an exciting field that they can make a huge difference in.
Thank you. And along the same vein, and perhaps Jennifer Vargo can also contribute to this discussion, similar to the Ohio Department of Education's teacher labor supply studies that are conducted, is there a discussion to do one of those on the behavioral health field since we keep hearing about workforce shortages in that area?
I do know from working closely with the Ohio Department of Mental Health and Addiction Services that they are very much aware that this is an issue, the workforce shortage, and they are doing or planning to do work specifically to this end. It is a very well-known need, and yes, they're working on it. I don't know the specifics of that, but I do know they're working on it.
Thank you. We'll take it back to Orman Hall. A few statistical questions here. Is there a statistic on Ohio deaths by socioeconomic status? And then kind of in the same vein, are there any statistics on male versus female deaths?
Those are really great questions. So from the standpoint of socioeconomic questions on the mortality data set, there isn't a specific question regarding income, but we do have a field that looks at educational status, which closely tracks economic status. So that would be one way, looking at deaths, suicides, and overdoses by educational status. We've done a little bit of that. And then the second way we could look at that is by doing a small area analysis, looking at deaths by census tract and township. And there are very distinct patterns, economic patterns when you do small area analysis. So there are ways that we can answer those questions. Don't have those statistics top of mind, but that's something that we can figure out. And I think, was there a question about gender, deaths by gender?
Yes.
So generally speaking, when you look at the ideation data, women are more likely to contemplate suicide, but males are more likely to complete. That is because men tend to use more lethal means. Men are more likely to use firearms to attempt suicide than females are, and are therefore more likely to be successful. So we have disproportionate numbers of males who actually die by suicide in Ohio.
Thank you for that answer. Going on to our next question, and this is for Jennifer Vargo. Do the mental health programs from ODE come to students in a reactive or proactive ways? In other words, do these programs come into play after something has happened or a student shows a need? And what programs are there specifically for prevention other than, or just addressing the issue afterwards?
Well, I think I could say that we're finally getting to a place where schools are seeing the whole child and needing to meet the needs of the whole child as part of their mission. And so we just did a survey. We surveyed all the schools in Ohio, and 70% of schools are providing some form of prevention education to their students. And I would say, from 5 years ago, that's substantial. It's a substantial amount of schools that are understanding and doing something about providing prevention education services. Sometimes we do react because, in the case with the pandemic, I think it really came to our attention how many kids were attempting suicide or going to the hospitals for attempted suicides. So in those cases, even again, partnering with the Ohio Department of Mental Health and Addiction Services, they're learning this information as well. So we react so that we can respond to that pressing need. But I would say, at least for the past 5 years, schools have been taking a greater look at what students' needs are. We're actually working with them on implementing the OES survey, and we're trying to promote them actually collecting data on students so that they know what the needs are and then can be preventative rather than reactive. But for a long time, I know schools have been working with mental health organizations just to do like small group instruction and those type of things. I think we're just becoming more sophisticated in understanding what the actual needs are of the particular schools and the students. And then they are doing a great job with now partnering with their mental health boards as well as providers to provide the right types of supports. So I think that that's just going to continue to increase. And like I said, there's a lot more peer-to-peer support, which wasn't there 5 years ago. I think just as people are starting to become aware of, how great these needs are, then it's more becoming a part of their core work.
Thank you for that. And I see that Senator Sykes has his hand up, so wanted to take the conversation over to you, Senator.
Thank you. Thank you so much. While we have this captive audience of these distinguished researchers and practitioners, I'm just wondering, do you all have any suggestions to policymakers for any changes that based on your experience and knowledge, do you have any recommendations to us and for any policy changes? Well, let me ask something more particular, specific. Ohio is, as you may know, is the only state in the nation that don't have health education standards. Do you think that that could be helpful or meaningful in any way to have health education standards here in the state of Ohio?
Senator Sykes,
Yes.
this is Ormond Hall. I'm a little on the slow side, so I apologize, but if I could maybe just take a second and answer your first question.
Okay.
And then I'll punt back to our other two clinical experts to maybe handle your first question. I do want to say that when you look at the delta between overdoses and suicides, when we started this 10-year period, in terms of the analysis that we just looked at, so the number of suicides and overdoses were roughly the same. But as we progressed through the 10-year period, the number of suicides have significantly outpaced the number of overdoses have significantly outpaced suicides. And one of the reasons for this is that the illicit drugs that drug users are exposed to have become increasingly lethal. So we don't have significantly more people dying from or using drugs. We have significantly more people dying because the drugs they're using are more lethal. And so I think from a policy standpoint, it's important for policymakers to understand that the drug supply is more lethal, and we need significant additional attention focused on how we can eliminate fentanyl and fentanyl analogs from the drug market in Ohio. And if we could figure out how to do that, we could save significant numbers of lives from the standpoint of people succumbing to overdose. And I really appreciate your question, sir.
Thank you. I appreciate your response.
Representative Sykes, I would say one thing that, and I don't know how this would come in the form of legislation, but I know that we need more of is more professional development and education for our educators on trauma-informed practices. A lot of what Dr. Ragland-Bernal was talking about is students getting suspended and expelled from school. It's a tragedy. And part of that has to do with educators not having the professional development that they need to really understand what's happening with children, which results in behaviors like anger and aggression, fights and all those things. I think, something that would really help our schools and our educators and our children, most importantly, would be a focus on trauma-informed practices and also on restorative practices. Both of those things combined together could really help, I think, to change our disciplinary practices, and could potentially also help the child who maybe is having a bad reaction to a fight go to another caring adult that's in their school building, where they could talk about what's going on. So maybe they would process that with somebody who's right there, and then would not make the choice to take their life. So I think, especially for children who are in poverty and have less resources and supports, and families that are stressed out, again, to what Dr. Ragland-Bernal was saying, when folks start to understand what's really happening with people, and why the behavior is the way that it is, and then what they could do about it to help support, I think that would go a long way in prevention supports.
Thank you. Could that professional development also include teacher education?
Oh yeah, it's one, yes.
Okay, thank you.
Thank you so much. And this is another question for Director Vargo. Are schools and students with IEPs being offered more supports after spending a year mostly remote?
I apologize, I cannot answer that question. That would be the director of our Office of Exceptional Children who could answer that question. I don't have that information.
All right, thank you so much. Yeah, another question, what collaboration exists between suicide prevention and alcohol and drug use prevention efforts in our schools? I think this is also for your Director Vargo.
Well, as I was saying, there's a lot of prevention education programming that's happening. So, for example, the Ohio Department of Mental Health and Addiction Services has a program, evidence-based program called Sources of Strength that they have provided more funding to get schools to give the professional development and to implement that program. So there's, I would say that there are more suicide prevention programs happening now than there were before. There's a lot more that are available. And now that there's the connection between the Ohio Department, between the school districts and their Adams board, which again, I think really came as a result of the last House bill budget that gave the 18 million to make those connections and to provide those prevention education supports. There's been an increase in both prevention education for suicide as well as for at-risk behaviors such as drugs and violence.
Thank you. This is a bit of a longer question, but one of the presenters spoke about firearms deaths and maybe perhaps not wading too much into the issue of gun control, but with the increase of stressors that could impact mental health, should schools consider increasing education on gun safety and/or gun storage to decrease firearm accessibility for children who could do harm to themselves or others? This question perhaps best suited for Director Vargo again, but I think anyone is free to answer, obviously.
I'm sorry, can you state the question one more time, please?
Sure. I think the question is mostly, should schools consider increasing education on gun safety or gun storage to decrease firearm accessibility for children who could do harm to themselves or others? So just a general question about, with what we know about self-harm among children on the rise, should we also look at increasing access to education on gun safety?
And that would be towards their parents. I mean, I certainly don't think it would hurt that. I think it's the role of the school to do that. I mean, and I think in terms of addressing suicide prevention, if they're doing outreach to families and they're having communication with families about suicide prevention, I think that makes perfect sense to include information about what families can do to help protect their child. That makes perfect sense to me.
Thank you so much. And this is a question for all the panelists. How can faith-based and community organizations partner with your organization or others on the panel to help provide services or support children and young people?
I'll take that one first. I think they can do a lot because they have a special relationship with their members and with their community. And oftentimes their members in their community trust them. And there's a lot of stigma about mental health and treating it. And so by partnering with faith communities and allowing us to come there and talk or show our faces or showing that we're totally not scary. It's not a bad thing to necessarily talk to a counselor. That can be really, really helpful. And some of the work that I've done in the community here, whenever some of our community churches have events, we try very hard to have a table there because we really want them to see that we live outside of the walls of this building and they can see our faces and that we can be trusted. And so holding fairs, having us come talk for 5 minutes during the worship service, I just think that there's many ways in which we can collaborate because we don't always see everyone. And if we can leverage some of the trust that the faith community has, we can do many things. And so building on their trust and their expertise as well as ours, I really think can make a huge difference in our communities.
That's excellent. Did any of the other panelists have comments on that?
Yeah, I completely agree. The stigma is real, and it really does prevent folks from getting help, and especially in particular communities. I think it has to be culturally responsive. And we need to focus on trying to find more or provide more culturally responsive practices in our mental health. I want to also just plug one more thing. I wasn't prepared for the question about what legislative actions would you ask us to take. I should have been knowing who's on the call. And I appreciate the question. I just want to say this. And one of the things that we've been noticing and trying to make these collaborations enhance collaborations between schools and mental health professionals, and they are growing. There is a tension that happens between the pay that our mental health professionals make and what educators make. So what we're seeing is that when we make the connection between the mental health professional and a school district, for example, a lot of our mental health professionals get hired by our school districts because mental health professionals want to go there, one, because the pay is higher, two, the hours are better in terms of having summers off. But it also, I think, does lessen, in doing so, it's somewhat a win for the school district, but not necessarily, because what a mental health organization provides, schools can no longer provide. They provide constant supervision. They provide professional development to the mental health professionals. And I also think so it's good to have mental health professionals that are in mental health professional organizations supporting schools, because they have the content and that expertise. And we don't want that to see that watered down by them being hired into schools to do some of these services. And I really do think it's a matter of what they get paid. A part of it is what they get paid. And so we're seeing this battle as we're trying to make these partnerships. We see schools hiring mental health professionals, and then there's already a drain on the mental health professional system. So it's just, pulling even further away. So I don't know what can be done about that, but I just wanted to bring that to folks' attention as a real issue.
Yes, thank you for that. That is very important to note. There's good discussion in the chat about school nurses and how that is a useful resource, and perhaps doing training on these issues for school nurses, and also requiring school nurses in every school district. Good discussion in the chat happening on that. I don't believe I see any other questions, but certainly don't want to cut things off. Were there any other questions? Oh, Senator Sykes has his hand up again, so please go ahead, Senator.
Well, again, I'm trying to get some information to help me be a better legislator. And so, these issues is very informative, very good information of how it affects our longevity, but also the quality of our life. And I'm just wondering, is there some mechanisms in place to share this information with policy makers on an ongoing basis, to bring it to our attention, to get our attention, so that we could possibly help determine or devise some strategy or craft some legislation to try to address the issue?
The senator asks really hard questions. Really good, really hard questions. And I don't know that there's a forum, but there should be. I would, just real quickly, without oversimplifying, the nature of the problems that we are confronted with in terms of behavioral health disorders. But I think the root causes maybe break down into three categories across the two diseases that we discussed. The first cause would be the significant sort of erosion in our society around social distress. So that's one thing that we all think about. The solutions to that issue are really hard. But the other two issues we've alluded to. Access to guns is driving the suicide completion in our society. So we've got to figure out how to and the question somebody asked earlier about education, we've got to figure out some way to make sure that those people who are susceptible to suicide have less access to firearms. And then the other issue, and I alluded to this, was the increasing lethality of the drugs that people are exposed to. We don't have more people using drugs, significantly more people using drugs. We just have the same number of people using drugs being exposed to more lethal drugs in the illicit drug market. So if we can work on those three things, social distress, access to guns, and the lethality of the drugs that people are being exposed to, we can affect significantly the number of people dying from suicides and overdose in our state. That doesn't directly answer the senator's very fine questions, but I think it gives us a framework of some things that we can begin to focus on that might make a difference in terms of the number of people dying in our state from mental health disorders.
And you provide very good and thoughtful responses. I appreciate it.
Thank you, sir.
Well, thank you again to all three of our panelists. You provided such good information for us and really helped spur an excellent discussion on this topic. This is a very serious issue taking place in our state. And I know for me personally, I care very deeply about the future of our kids in the state of Ohio. And obviously, this is something that I think needs to be addressed from all sides. And you provided us as legislators with some very good suggestions on things that we could perhaps take up. And I can even say for myself that I took a trauma-informed class and it actually changed my life and the way that I view people. So I would highly recommend, if any of you have access to something like that, it really is a useful tool in the fight on mental health for our children. So again, thank you all for participating today. I hope I got to everyone's questions and you all have a wonderful rest of the week.
Thank you for the invitation.